Merhaba.
Good morning. First of all, I would like to express my thanks to the organizers for their invitation, and I would like to thank the organizing committee. I will talk about different approaches for treatment of social anxiety disorder.
15-16 dakikalık bir sunum yapacağım. Baktığımızda
In 16 minutes presentation, children with social anxiety disorder in our daily lives have many problems in different fields. It might be about starting with a dialogue or initiating a dialogue or reading in front of people or getting introduced to other people, or it might be some sort of a performance anxiety, and they might feel limited because of their anxieties. Those coming to our centers have accompanying psychiatric conditions, and the social anxiety disorder might lead into the emergence of new psychiatric situations like depression, substance abuse, and this limitation brings along suicidal tendencies as well. And its incidence is quite high. Its lifelong incidence is 10 to 15%. 75% of the cases say that the first symptoms were seen at the time of adolescence. And the studies among adolescents show an incidence of 1%. If at an early age we see this problem emerging, and if some of the cases become chronic patients in the following years, and if the comorbid situations are many, then we cannot discuss how important it is to treat the problem at early ages, because not only in terms of education, but also in terms of economic conditions, it might bear along a bigger burden. In terms of treatment approaches, we first have psychotherapy. There are 3 different trials on this matter. There are 3 different treatment modalities. Pharmacotherapy is important, but SSRIs are really important because both in open label and other studies, their efficacy have been proven. Combined treatment is another treatment approach. No combined treatment is present other than only one. When we look at the trials, we see psychoeducation as the first title. Why do we have social anxiety? What kind of education has to be given to such population? And then comes the corporate sensory reactions of the child and its relationship with the mood of the child. And also then we have beliefs, fate, and a post-educational process which brings along alternative ideas on the same matter. This makes up the second session. And then coping mechanisms with anxiety, and how can we acquire skills contributing to our social abilities, and then exposure. Albano has developed a manual on this matter, and there is a program called Stand Up and Speak Out. This is a group treatment format, 16 sessions. Only 16 of them are attended by children. In 4 of those, the adults also participate. The first 8 are about psychoeducation and acquiring social abilities. It is in the form of a course. A trainer, a therapist is giving this course to the child for 8 weeks. In the other 8 weeks, role plays are made, exposure is carried out, and then homeworks are given, and this is then transferred to real life conditions. individual psychotherapy or group psychotherapy? It looks like individual is more efficient when we first think about it, but group therapy is important in terms of time and cost as well. In a study carried out for this purpose, it was seen that there is no immediate difference between the three different groups. I mean, both those three methods do not yield different results. But in month 6, group psychotherapy gives better results. I think it's because of the role plays and the skills acquired, which are transferred to daily practices. It is a bigger advantage in terms of those components. Group psychotherapy, in the long run, has a certain efficiency. Let's see how that efficiency is. Its efficiency continues in the long run, and it prevents from depression. Social anxiety disorder's vicious cycle is broken, and the coping up skills acquired also act as preventive components for depression. What about parent involvement? Is parental anxiety something affecting child anxiety negatively? Yes, it really is the case. Over-control, being overprotective, and the child not being able to develop their own skills in a social environment have a negative effect on this. When they ask a question to the child, the mother immediately says, our child is very timid. This is being overprotective, and this supports the anxiety of the child. Or if you say, don't go anywhere, and if social interaction is limited, then this becomes a very problematic thing as well. And the parent becomes a model with its own behaviors too. For example, if the parent is isolated and has confrontation problems, then this is also perceived in the same manner by the child. And restricting social interactions of the child are also supported sometimes by the parents. Or they may say the child has been very nice and proper when they went to visit a friend, and they support this type of behavior. And what about the practices which are involving parents and which are not involving parents? Which one is better? During each and every treatment, anxiety and that vicious cycle can be prevented by the parents, and this is taught to parents. Social skills supporting social interaction, facilitating behaviors are also supported for the parents, and as a result of this, the control group, which means the group which is not included in the treatment scope, lose their definition of social anxiety disorder on a 7% basis. When it is only the child, it is 8%, but when the parents are involved, the same rate is 87%. Although the parents involving groups and therapy programs have such low additional value, we know that the anxiety symptoms of the mother are also important, and in order to increase treatment compliance, the parents should also participate in the treatment program. Another treatment and therapy method is social effectiveness therapy. It is in a group format. Its difference from the previous one is that it involves no cognitive component. Only behavioral therapy is included here, and children without the anxiety are also involved, and the main purpose is some sort of an interaction. And the results of this method are also quite promising. What is interesting here is that anxiety is reduced. Social anxiety disorder definition is reduced on year 3 and year 5 after the treatment. The well-being continues, and revisit to psychiatric clinic or center is prevented. Cognition targeting and cognitive therapy targeting approaches might be useful in this area. This is a trial from Germany conducted in 2011. If we simplify the program down to the level of the child, and if we use stories and puzzles accordingly, and if we treat and if we design the treatment accordingly, we can come up with very good results. Can we simplify those treatment programs to the school level? Can we really be successful if the guidance is given accordingly? Social efficiency therapy and group CGBT can be modified in order to give this sort of a training. The results are promising here too. If such programs are school-based, then good results can easily be obtained. Is there a difference between different programs? 3 treatment programs are compared in this trial, and in terms of long and short run, the efficacy continues in all 3 groups, and this effect is equal in all of them. Psychotherapies are so effective, but when should we use pharmacotherapy? If we have an evidence-based psychotherapeutic capacity, then it's okay, but if you do not have a training, psychopharmacology can be used. If the functionality of the child is disturbed by this higher level of anxiety, and if we have to intervene in the acute period, pharmacological agents might become more important, because psychotherapeutic treatment results show themselves at a later stage, and if the social anxiety is preventing the child from attending a social activity, then this method be used. And if pharmacology can be the preference of the family, it also can be used at the baseline. And if the comorbid conditions require drug treatment, then it is possible. And open trials show that 1/3 of the cases do not respond to treatment. This is obstagram trial. Again, 1/3 of the patients do not show any response. When mirtazapine is used, the anxiety level is reduced, but half of the cases drop out from the trial, especially because of sedation and weight gain. This is a trial from Turkey. This is a 60% response rate. And in order for us to get good results, early age becomes the most important predictor. Lack of depression and anxiety in the family is an asset, and the anxiety level before the treatment should be low. These are double-blind trials. I'd like to draw your attention to the last column here. The number of patients to treat. When you look at the group with social anxiety, and when you exclude the placebo effects, in trials carried out with paroxetine, these are 2 randomized trials, you see 1 out of 2.6 patients can get better. And with venlafaxine, this is 5.3. If we exclude venlafaxine, the number is good. When placebo effect is excluded, you can get results in every 1 out of 2 or 3 patients. In depression, the same figure is 8 and 9, but for social anxiety disorder, it's a good figure. In the study for venlafaxine, the effect is lower, and interestingly, in 3 of the patients, you can see suicidal tendency. So should it be CBT or pharmacotherapy? SSRI treatment is shown to be the most effective method, but I'd like to emphasize that the duration of the treatment is 12 weeks, and this is an advantage for SSRIs. I mean, 8 to 12 weeks are required for the SSRIs to reach a maximum effectiveness level, but the results of psychotherapeutic results are yielded at a later stage, so this might cause some sort of a bias. This is the most important slide. Fluoxetine and social activity treatments are compared to placebo, and fluoxetine and therapy methods are found to be effective, but interesting thing is that in acquiring social abilities, the only method which is useful is social effectiveness therapy, which means antidepressant treatment prevents the somatic findings and arousability, but in the long run, it has no effect in social skills. In pragmatic skills, fluoxetine and placebo, or in terms of using the gestures during speech, there is no difference, but the effectiveness of the therapy is significantly higher. Finally, I will talk about the combined treatment. This is an open-ended treatment, the trial. Sessions are 15 minutes. Behavioral method of 15 minutes is added to sessions, and they see that the combined treatment gives a success result of 83%. The other anxiety disorder-related trials, where you see 4 different branches and a population of 488, show that combined treatments is the method which gives us the best result in terms of improvement. The other interesting thing is that when we combine sertraline monotherapy is not that effective because we use a less amount of sertraline. But there are 2 things to be emphasized here. Firstly, the short-term results in the MKA trial. It is shown that combined treatment in the short run, when compared to the other treatments such as psychosocial and medical treatment, have better results. But in terms of the long-term results, there is no difference. And the data about the adults show us the same thing. Combined treatment is not different from the other treatments in the long run. So long-run results of this trial might be quite interesting. While ending my words, I would like to make a short advertisement. 3 weeks later, we will have our autism meeting. Right after the psychopharmacology meeting of the next year, we're going to have our National Pediatric Psychology Congress.